non-atherosclerotic ACS or non-atherosclerotic coronary artery disease, OCT in that. So probably I will show you a few interesting things. Most of us, we have been discussing on atherosclerotic ACS. And now look at this angiogram here. So this patient had a stent here, and then almost around 6 months to 8 months later, he comes like this. So what do you think this is? So basically, most of us, when you look at the angiogram, you feel probably there is a ruptured plaque or there is a thrombus there or something is happening. If you want to treat it, ideally, for such cases, better. He had a stent in the RCA also, which had a problem, which had occluded. You look at the OCT here, what it clearly is showing is there is a stent, and after that there are ectatic segments here, very clearly seen there. And then probably this is not a problem with the atherosclerosis. Probably this patient you can just imagine what it is. And this is the OCT here, and it's basically a polymer hypersensitivity. So but this is what the angio shows, as well as the OCT shows very clear ectatic areas. A similar case you see here, a stent looks like this, and then this is the IVUS, which shows that there are ectatic areas there in that. And again, this is not a stent problem, it's an hypersensitivity reaction to the polymer. And a similar case here with such a big ectasia, you can clearly pick up on angiogram that it is an ectatic segment at the stented area having a problem. And here, this patient also had a huge aneurysm there near the stented segment. And this is again a polymer hypersensitivity here. This was treated with a covered stent. And probably this is how a covered stent looks on an OCT. You cannot see anything beyond the covered stent because there are layers there. And this is one. And apart from this, one important thing that we should remember is spontaneous coronary artery dissection, or SCAD. So it's a non-traumatic non-iatrogenic separation of the coronary arterial wall, commonly in younger women. And there are so many reasons behind it, which we will discuss. And there are different types here. So one, it can just have some intraluminal defects. One is they can be a diffuse disease or a focal disease, just mimicking atherosclerosis. So this is a very standard definition of an SCAD there. So look at this angiogram. So this patient has some long lesion in the LAD here. And when you do an imaging in such a patient here, what is it that you are seeing there? So very clear, you cannot make out in an angio what it is. You see here, it is a separate hematoma in the area between the media and the intima. And in this specific case, you see that intima is completely intact. There is no tear in the intima, but there is a separation between the intima and the hematoma. And in the media, that's because of intramural hematoma. You analyze the OCT, clearly it shows there is a separation. And this is producing an image as a diffuse disease on an angiogram, which is very important that you cannot take there. And most of these patients can be treated medically, and there is no need for stenting looking at the lesion like that. And this is a very important tool, especially OCT, to look at the spontaneous coronary artery disease. But you need not do a OCT in all SCADs if it is very proximal, or if there is a tear, you expect that you can extend the dissection. But in many cases, when there is a doubt, this is how it looks. And coming to the pathophysiology, it can be a tear in the intima and going to the media, or with the intact media, there can be microvascular ruptures which cause this spontaneous coronary artery disease. See here, there's a rupture and the intima is intact, and then you get a lesion like this. And this is again a SCAD here, but you are seeing that there are intraluminal defects on an angio. Should we stent it or not? So you do an OCT, you see that there's a thrombus, and when you concentrate on this, there is a tear in the intima and there is an hematoma going inside. And you concentrate this segment, you can clearly see that there is a tear and there is an intima medial involvement there causing this picture. You look at this angiogram, and there is a very focal lesion there in this lady, which was directly stented. The moment you stent it like this, it's a very focal lesion. And then after the stenting, we were trying to dilate this lesion. See, what was happening is, once I dilate the distal part, the proximal part of the stent became stenosed. And once I dilate the proximal part, again, the distal part becomes stenosed. So what is happening is I'm trying to dilate it with the NC balloon after stenting. The plaque is getting shifted. It is from above to down, down to above. So this was really a puzzle. Like actually, we did not do an imaging just before the stenting there in this case. And since we had this problem, the shifting plaque up and down, the moment you dilate here, again, it goes there. And I did a HYBIZ. It clearly showed that there is a hematoma which is moving up and down there. Probably this was not a atherosclerotic lesion. Probably it was a SCAD that we have stented there. And again, look at this angiogram pictures. There are intraluminal defects. So it is a recanalized thrombus. So the difference between a SCAD and a recanalized thrombus is limited to the lumen. There is no break in the intima and there is no involvement of media. But in the SCAD, it's predominantly a layer between the intima and the media which gets involved. And here you get a lotus root appearance with multiple channels there. And this type of patients, you can decide whether to treat it or not. Probably many times the FFR is positive in such cases. Or you can look at the effective lumen area. You can measure all the lumens of all the recanalized thrombus. And you can look at what is the effective lumen area, and you can take a decision whether to stent it or not. So this is a thing. And other important things today is minioca, where you have a non-obstructive coronary artery disease or a normal coronary artery disease with findings where there are a lot of publications which shows that when you do an OCT in such minioca cases, the common causes are probably a SCAD or hematoma or a fissure and a ruptured plaque. This is what you see in all minioca cases. And this is also another interesting paper where they have said that in minioca, these were the OCT findings that they have seen there. And to remember today, when you are looking at it, when looking at an acute coronary syndrome, when you come across a classical angio, there is no problem. But when there is a non-obstructive coronary artery disease or the coronaries are normal, then probably the role of imaging is very, very important. You can pick up the exact reason for that. And along with OCT and HYBIZ, today cardiac MRI also plays a great role in diagnosing cases where there is a controversy. This cardiac MRI can clearly make out whether it's an MI or is it a myocarditis or is it amyloidosis many times, which is mimicking coronary artery disease, or is it a DCM? And this differentiation is very much possible with cardiac MRI. And I'll conclude here saying that imaging is indispensable in coronary artery disease today. And most of the occlusion, atherosclerosis is the cause, but it might be presenting in a different way, which you need to do imaging to make out. And non-atherosclerotic pathologies are not uncommon. You usually you come across them, and image guides in proper diagnosis and treatment. Thank you so much.
Yeah, thank you. Very nice lecture. We learned a lot. I think that imaging can help us in taking the right decision. But I have a specific question. You very fast mentioned that with SCAD, there is also the risk of worsening the
Correct.
SCAD itself with OCT. So can you suggest us, okay, obviously, if we have a clear diagnosis by the angio, it's enough. But sometimes we have some doubts and we need imaging. So can you suggest us when we should use OCT and when not we should use OCT for the final diagnosis of SCAD?
See, the cases which I showed where typically by angiogram you really cannot diagnose that it is a SCAD. And there was no TIMI3 flow reduction. That is, if there is a very good flow and if it's a lesion is very somewhere in the middle, and when you are not sure about the diagnosis, definitely you should do an OCT. When probably we should avoid is if there is a TIMI3 flow reduction, like if it's a TIMI2 flow, and you feel there is something on the angio itself producing a dissection in the proximal part, probably you should be a little bit careful when you do OCT. HYBIZ also is useful, but the problem is it may not pick up dissections so clearly as in OCT. And these are very, very useful in young ladies or in people where the other vessels are completely normal. You have a very focal lesion and which you are thinking that probably it is not an atherosclerotic lesion. And many times these lesions were accidentally picked up. We did not think that it is a SCAD and did not do, since we do routine imaging before angioplasty in most of the cases, and since it was a diffuse disease, We picked it up accidentally on an OCT, showing that it's a SCAD, not an atherosclerosis.
So the
CT
last
angiogram
presenter?
will not show SCAD. You cannot make out very clearly that whether it is a SCAD. And probably OCT is the investigation of choice here.
Okay, thank you. We move
Thank
to
you.
the last